Hi friends, I'm Dr. Praveen, and in this video we'll be discussing about the blood banking and the transfusion medicine practices. As you all know, it's a very important field nowadays. It's a new branch also in MD in transfusion medicine. So you ought to get some questions that is actually minimum of range of 2 and 3 from this topic. I decided to make this video getting enormous requests for the blood banking and these topics. Let's discuss this like a story. Have you ever gone to donate blood? If you have, you will first be watching that when you go to the blood banking, you first fill out a form. In that form, you are destined to write some of the details. Then that is checked by the blood banking transfusion medicine officer. You then taken your weight and pulse and blood pressure. If everything is okay, you then move to the next table in which you are allowed to donate the blood. First of all, who are those people who are eligible to donate the blood? That is the first question. So usually we take as the age of between 18 to 60 years are those who are fit to donate blood. Those people who have this typical weight of more than 45 kg at least should be donating the blood. Okay. Now when you go to the next room, you will always find there is some sort of table like this. In this type of table, you will be asked to lie down as comfortable as possible, and then with a good amount of comfort level that you have, the cephalic vein is then cubital fossa vein that is actually palpated, and from there the blood is taken out. Okay. Now we need to understand that what amount of blood are you donating. Usually the blood bag components, the blood bag, it has usually 350 ml or the 450 ml. There are two types of blood bag. One is a 350 ml bag and one is the 450 ml bag. Usually if we are actually wanting to prepare platelets, we often prefer 450 ml blood. Else if you don't want to prepare platelets, we take the 350 ml bag. Okay, the first point. Secondly, you might be noticing these blood bags have some prior additives, which before you take the blood, you will see a small amount of actually fluid in the blood bag. That is called as blood bag additives. Let's see that blood bag additives. The blood bag additives usually used, okay, they are like CPDA, SAGM, SAGM, and though not used nowadays, but ACD was used previously. Now what I'll do is I'll just write here what do they contain, right? And on the right side I'll write what is the shelf life of this. Shelf life of the blood that you actually can prepare out of it. Like, look, the CPDA, it has the components are citrate, phosphate, dextrose, and adenosine. This adenosine, it actually is the ATP content. Okay, this provides the ATP. Dextrose, it provides the energy for survival. And citrate is basically here the anticoagulant. Okay, this is the anticoagulant. Then came the shelf life, which was 35 days for CPDA. Okay, most of the blood banks have CPDA. Most of the blood banks have CPDA as the blood bag additives. Then came SAGM. SAGM stands for saline, adenosine, glucose, and mannitol. Okay, so obviously the glucose again provides energy. The mannitol here, it prevents hemolysis. Mannitol, it prevents hemolysis. Okay, it decreases hemolysis. The usual shelf life of this mannitol is around 42 days. 42 days, very frequently asked question. 42 days for SAGM. ACD, it stands for adenosine, citrate, and dextrose. But this is not used by most of the blood bags because the reason is very simple, because the shelf life of this is just 21 days. Because of such a low shelf life, this is not used nowadays. What we use nowadays mostly is some blood bag use SAGM, but usually what is more available is CPDA. Okay, SAGM is a bit costly, therefore the blood bags don't use that mostly. Now, once you have donated the blood, so that bag is now ready, right? Let's think like a story now. What you do is, first before you take the blood, you also take the blood sample for those patients. Okay, that means along with the blood bag that you filled, you also take the sample for testing. So what are the tests performed? Tests done usually for usually transfusion transmitted infection, TTI. They are like HBV, HCV, HIV, malaria and syphilis. Okay, so these are the 5 main tests done for transfusion transmitted infection. As you all know, friends, if any of this is positive, the blood is not given to the recipient. But if all of them are negative, we then process it further. Okay, also remember, if any of them are positive, it should be given to the that donor should be informed, and proper, I'll say, advice should be given to that donor, right? So if all of them are negative, then we process further. Okay, now apart from these TTI, even though there are some other tests also, like I can tell you about Cmv Cytomegalovirus. So Cmv is a very important infection, which is also transmitted, but you don't test for it. Okay, we don't test for it. And HTLV1 and HTLV2 is also transmitted by the blood bags, and there can also be a transmission of the parvovirus. There can even be a transmission of some other bacteria and the hepatitis virus. Okay, especially the hepatitis G viruses. Okay, what is G? Okay, so but these 4 are not tested for. That is what you must also remember. Okay, now once you have the blood bag with you, imagine that you have this blood bag with you. Okay, this is the blood bag. This bag is filled with this blood here. It's a whole blood here. Now what we do, we centrifuge this, right? Once you centrifuge this, what will happen is 3 layers are formed of this blood bag. The lower one will have the packed RBCs, this packed RBCs here. Above that, there will be platelets, there will be some buffy coat, that is WBCs, and above that there is plasma, like this plasma here. So 3 components are well formed. I'll just label this. This is the PRBC. This is the buffy coat, which has WBC, and this is the plasma. Now, because this plasma has the platelet inside it, we can call this platelet-rich plasma, PRP. Platelet-rich plasma, that is PRP. Okay. Now, what we do is we connect a bag here, and we connect a bag here. Yes, we connect 2 more bags here like this. Actually, this bag are priorly connected to it only. You don't need to connect it separately. And then you press on this central bag. This central bag you are seeing, this compress it. Once you compress this, all the PRBC will flow here, right? All the PRBCs will flow to the next bag. So this PRBC, it comes here. This plasma, the plasma here, it goes to this bag. So this plasma here. What is left in the central bag? The central bag has only buffy coat, right? So because the central bag only has this buffy coat here, what we'll do is we'll just throw this back, because buffy coat basically has WBCs, and WBCs are source of infections. We don't want the recipient to get any source of infection, so we never transfuse this buffy coat to the patient. Now what we have got is, we have got a PRBC bag, right? This bag is the PRBC bag, and this is the platelet-rich plasma bag. Okay, this is the plasma. Now, once we have got this plasma bag, okay, this plasma bag is again centrifuged. What will happen is, all the platelets will come below. All the platelets will come and settle below. And what is remaining above is now the platelet poor plasma. Okay, what is now remaining above is the platelet poor plasma. So 2 layers are now formed here. The lower layer, it is the platelet concentrate. The lower layer, it is the platelet, and this is the platelet poor plasma. I'm writing this as PPP. So lower layer is the platelet, and the upper layer is the platelet poor plasma. Again we will connect a new bag and will transfer this to the next one. Okay, this will again be transferred to the new bag here. So what is this new bag has? This bag has only this platelet concentrate now. What we have now made is platelet concentrate. Platelet concentrate. And what is left in the above bag? What is left in this above bag, as see here, what is left in the above bag is just a platelet poor plasma. So friends, what have we made till now is a PRBC. PRBC. This is other bag which has the puffy coat. We just throw it. This is the plasma. This is the plasma. And you see this one had a platelet poor plasma and the platelet. And because I separated out, all the platelet has come to the new bag. So we have made all the components that we want. We have made the PRBC, we have made the plasma, and we have made the platelet concentrate. Now, what is cryo precipitate? See, this plasma here doesn't have platelet. If you take it and keep in a fridge, that will be called as fresh frozen plasma. You kept in a fridge is fresh frozen plasma. Now a call comes for cryo precipitate. What do you take out? You take that fresh frozen plasma out of this fridge and you connect it to the next bag. Yes, one more bag. So what happens? Suppose there is a fresh frozen plasma. This is a FFP here. Okay, I'm just again putting this with yellow color. This is the fresh frozen plasma. Let's call this FFP now. FFP now. We connect it to the bag and hang it overnight. Okay, so for 12 hours, all the plasma will trickle down here. All the plasma will trickle down. What remains above is the cryo precipitate. What remains here is the cryo precipitate. Got the point? So all the plasma will settle go down below, and what remains here is the cryo precipitate. What remains is the cryo precipitate. Got the point? Now, once you know this amount of knowledge, it is very simple to correlate everything. What we'll do now is we'll try to understand how and where do you store these bags. Okay, so we'll take this one by one again. We'll make a table out of it. So PRBC, I'll write the storage temperature, the shelf life. Okay, storage temperature and the shelf life mostly. So PRBC is stored at 2 to 8 degrees Celsius, and depending upon the additive we have used, 35 days to 42 days. Fresh frozen plasma FFP at minus 30 degrees Celsius or lower, 1 year is the shelf life, 1 year. Next is the cryo precipitate CP. CP is again stored at minus 30 degrees Celsius or lower. Shelf life of this is again 1 year. 1 year. And the platelet concentrate is stored at 22 to 24 degrees Celsius, and the shelf life is just 5 days. Shelf life is just 5 days. Okay, shelf life is just 5 days. Now I have been asked sometimes, sir, in which of this we need to do the ABO compatibility testing and which of them may not be used. So if you have to add one more information, compatibility. Compatibility. So in PRBC, you do ABO also and RH also. ABO as well as RH. For fresh frozen plasma, we just do the ABO. ABO. For cryo precipitate, you can go any group because there is no plasma, no RBC. So any group can be given. And the platelet concentrate usually is taken by the ABO compatibility. So RH is not so important, but we definitely need to check for the ABO compatibility. Okay, RH is not so important in the platelet. Okay, platelets. So you have prepared everything and you have in your department. Point is, what is a cryo and what is a FFP? Now see simply. Basically, FFP has all coagulation factors but is relatively deficient in factor 5 and factor 8. This is the first information you should have, has been asked multiple times in NEET. Okay, cryo precipitate, it has factor 8 and VWF and also 5-renogen. So if you know these, can't we guess what is the indication? Well, indication of fresh frozen plasma. Any factor deficiency. Any factor deficiency. You can give fresh frozen plasma. But the indication of cryo will be very specific. Either factor 8 deficiency, so what is that? Hemophilia A. Or von Willebrand deficiency, so VWD. Or if the patient has less fibrinogen, so hypofibrinogenemia. Hypofibrinogenemia. The three main indication of cryo precipitate. Okay. So we have seen the storage temperature, we have seen the additives, and we have seen the indication. Okay. Let's now move to what basically is the random donor platelet and the single donor platelet. Okay. See, what happens is, if you take platelet from a single person, the amount is so less, it will not help the recipient. So what we do is, we mix 5 or 6 random donor of the same blood group and mix it to make a random donor platelet. So random donor platelets. The important fact is, random donor platelet, it basically is a mixture of 5 to 6 donor platelets. It increases platelet count around 5,000 to 7,000 per bag. Okay, this is a random donor platelet, short form RDP. While a single donor platelet, this is taken only from a single patient by a machine called as apheresis machine. It's taken by apheresis machine. Some, if you are practicing, you could be calling this jumbo bag. Okay, it's a large platelet bag, and this increases platelet count by around 30,000 to 60,000 per bag. But because this requires a special technique to take it out as apheresis machine, and therefore it's not very easy. It's not very easy to take this sample. Like this is, see, this is a single donor platelet bag. It's a large jumbo bag, and the amount of it that is got is very high. And this is the machine. So what we do here is, if you have seen this machine, what we do here is, we actually take the blood of the patient, put in this machine. So this is a rotator here. Okay, this is a rotator. It keeps on revolving like this. This rotation movement, it separates out the platelets, and all the rest of the blood is given back to the patient. But the point, you take out the blood and you just separate out the platelet here. You see this bag? This is a platelet bag, and the rest of the blood is given back to the patient. So what happens is, you are able to take more amount of platelet from the patient, and therefore called a jumbo bag. The amount of platelet you're getting is quite more. Single donor platelet. Okay, this is a machine called as apheresis machine. Now, once you know this, let's now move to the next fact. See, we have already covered with you. Now comes the question: when do you want to start this, and when you want to end this in the wards? Okay, that means the components and the transfusion. Again, a very important concept. Component wise, if you talk about the RBC, that's PRBC, it should be start within 30 minutes, and is completed within 4 hours. So once you take this PRBC from the blood bank, start within 30 minutes and end within 4 hours. Suppose you have taken this platelet at 8 AM, start by 8:30, finish 8:30 to 4 hours is 12:30. But the point is for PRBC. This is for PRBC. For platelets, start immediately. immediately, and you can end this within 30 minutes. Okay, you can end this within 30 minutes. About the FFP, again you start immediately, and it's completed within 2 hours. Okay, it's best if you complete within 30 minutes only, but you can take 2 hours. But it's better you to take within 30 minutes. But the book language is always 30 minutes. Okay, do it within 30 minutes. Now, once you know this, comes a simple question. Suppose you took 4 units of PRBC, 4 units of platelets from the blood bank. What should you do? A simple logical answer looking at this is, first give platelets, finish it within 30 minutes, and then start the PRBCs. Because platelet transfusion will just take 5 minutes. So even if you get 4 platelets together, you will give maximum 20 minutes. And then you can give the PRBC, which is the logical question asked in the AIIMS November 18. First gives platelets, and by the time don't put this PRBC in the refrigerator. You should never put the PRBCs in the domestic refrigerator of the fridge, of the wards. Just keep in room temperature. It will not get bad. It get bad only if you keep it within, say, after 1 hour. So once you have completed the platelets within, say, 20 minutes, you can then start on giving the PRBCs. Okay, this was a question asked in AIIMS exam, in the AIIMS November 18 exam. Okay, so we have considered all of this basic facts. Let's now move to the topic of blood grouping, blood groups. Now, the basic thing we should know is the major blood groups are A, B, AB, and O. And then there is a RH, that is called the D antigen, D. But there are some many minor. Minor are like M, N, S, Lewis, Duffy, Kell. There's so many that enormous. Okay, so we are mainly testing for the major, and then if required we will also test for minor blood groups. These major blood groups A, B, AB, and O, and these 4, they actually are derived from what is called as a H precursor antigen. So what happens is this H precursor, it gives rise to A. Let's assume when the enzyme 1 acts, enzyme 1, that is starting E1, okay, it makes A. When enzyme 2 acts, it makes B. When both enzyme 1 and 2 acts, it makes AB. And when none of this enzyme acts, it makes O. Okay, again repeat. So what happens is, in the H precursor, when the enzyme 1 acts, it makes A. When enzyme B acts, or enzyme 2 acts, it makes the B. And when 1 and 2 both acts, it makes AB. And when none of the enzyme acts, it just remains O. But all of them have come from a common precursor called as H precursor. Once you know this concept, comes to the next heading. See, let's write the blood group here. Blood group. The antigen they will have on the RBCs, antigen on the RBCs, and the antibody in plasma. Okay, antibody in the plasma they should have. See, blood group A will have the A and the H. H will always be there, right? Because H is the precursor. So antibody will be anti-B. The important point to know is the ABO is a naturally occurring antibody. Naturally occurring antibody means that if my blood group is A, I will naturally have anti-B antibody. I need not be exposed to the anti-B or the B antigen, I will then get it. I have naturally occurring antibody, that is anti-B. And hence ABO is a naturally occurring antibody, which is not the case of D. If I am D negative, I won't have anti-D. So D is not a naturally occurring antibody. It is only the AB which is the naturally occurring antibodies, right? Next is B. It is B and H. The antibody is anti-A. O. It has only the H, and so has anti-A and anti-B both. And the AB will have A also, B also, and H also, and therefore has none of these antibodies. They don't have any antibodies. Okay. Now, once you know this fact, let's come to the main thing I want to discuss here. And take a red pen and write here: Bombay phenotype. Bombay phenotype is a unique blood group in which there is neither A nor B nor H. H is also not there, and therefore because the natural killer antibodies, they will have anti-A, anti-B and the anti-H also. Got the point? It has anti-A, anti-B and the anti-H also. Because it has anti-H also, let's try giving this person other blood groups. Try giving him A. The A reacts with the anti-A. You're giving the PRBC of the A blood group, you can't give him because A antigen here and the H antigen here will react with anti and anti-B. B and H will react with anti-B and anti-H. O, the universal donor. Oh, he can also not give it, right? Because the O has H antigen and he has anti-H antibody. A, B will definitely not be able because everything will react. There's more severe reaction. The only answer was a O blood group. You cannot give even the universal donor OPRBC. This person will require transfusion only and only from his own blood group, Bombay phenotype blood group. There's no other blood group that you can give to the patient. Only you can give is Bombay phenotype blood group. No other blood group is permissible for this unique person. Well, this unique person comes to your city and he stays there. What he should do? Should he bring a friend along? Should he bring a person who also has Bombay phenotype? Well, no one can do that. What he should do is, he should keep on donating blood for himself into the localized blood bank, in the local blood bank. And if required, that blood can be given to him. So he should be repeatedly donating his blood for himself to be given. That is the one thing that he can do. But yes, there are some blood banks who actually keep Bombay phenotype. It's very, very rare though. But only rare in practical cases. For MCQ, very, very, very common. Now, so friends, when you know this, what we actually know is universal donor, universal donor. Let's not put Bombay phenotype now. Let's take out that. Universal donor is for PRBC. For PRBC, it is the O, right? O, because O has only the H antigen. And for FFP, whom will you take? If you're getting fresh frozen plasma, you want a person not to have antibodies. And who doesn't have antibodies? AB. So AB is the universal donor for fresh frozen plasma. Now suppose the question is, for FFP you want to give AB positive or AB negative. In true sense, it doesn't matter much. But if you have followed my concepts very clearly, I told you beforehand, how do you prepare FFP? By this method, you're compressing this. Suppose a small amount of PRBC goes to this FFP, and this PRBC has the RH antigen. So this PRBC will also, this FFP will also be contaminated by the RH antigen. So why to just take a risk? Give a patient who has fresh frozen plasma of AB, so no antibodies, and RH negative, so even not any RH. That means if you want to choose one of the option, I will say the better option is AB negative more than AB positive. In true sense doesn't matter much, but because there is risk of RBC contamination which can occur in the FFP, so better give the AB negative antigens. Right? Now come to the testing of the blood. Okay, that means blood grouping. Now what we do in blood grouping is, we take this slide, okay, and what we do, we first put patient's blood, okay, and then you put the antibodies. See how. Let's say this is the three areas. So I have taken the patient blood in these, and what I am putting is, say, anti-A, anti-B and the anti-H, right? So when I put this anti-A, anti-A and anti-H, suppose there is an agglutination in the A. Okay, in the B it is negative like this, and in H also there is agglutination. That means the anti-A here has reacted with the blood of the patient. So that means anti-A, you have added anti-A. Why will it cause agglutination? Because the patient blood has A. Why is anti-B not reacting with this? Because patient does not have B. And why is the H and T reacting with the patient? Because he has H also. That means in this case, what is the patient blood group? It is A positive. A positive. Simple. If you have the concept, it's very simple. Else, you'll always get lost in what is happening here. So let's show you this image also. How does it look like? See, this is how it will look like. See, this is the A positive, B negative, and R, that is RH positive, becomes A positive. Look at the next one. B is getting positive. This is agglutination. This is the small dot agglutination. So it becomes B negative. Here you see A also negative, B also negative, and R is positive. So it is O positive. And look at the last one. A positive, B positive, but the R is negative, and hence it is AB negative. AB negative. Okay, this is how you look for the ABO blood grouping. ABO blood grouping. This is called a slide testing. It's called a slide testing of these blood samples. Slide testing for these blood samples. Okay, so now we have taken the blood sample, we have done all the tests, and we have given it to the patient. What can happen? The patient may have transfusion reactions. Agreed? Transfusion reactions. So let's come to the transfusion reactions. Well, transfusion reactions, as you all know, it can be immediate or can be delayed. Okay, transfusion reactions, it can be either immediate or can be delayed. Let's understand now what are the immediate and the delayed type of transfusion reactions. Okay, immediate and the delayed type of transfusion reactions. Let's see that. The immediate and the delayed. Immediate transfusion reaction, delayed transfusion reactions. See, what is quite possible here is in immediate, there can be immediate hemolytic, and can be non-hemolytic. Immediate hemolytic transfusion reaction or can be immediate non-hemolytic transfusion reactions. The question is, what may cause hemolytic transfusion reactions and what may cause the non-hemolytic transfusion reactions? Okay. See, now any case of hemolytic transfusion reactions, immediate, it can be hemolytic and non-hemolytic. The non-hemolytic may include FNHTR, which is the most common one, the full form being febrile non-hemolytic transfusion reactions. This is the most common one. Okay, it can be allergic, it can be anaphylaxis, okay, it can be anaphylaxis or can be TRALI, which is transfusion related acute lung injury. Transfusion related acute lung injury. It can be bacterial contamination or can be circulatory overload called as TACO stands for transfusion related. So transfusion associated circulatory overload, transfusion associated circulatory overload. What is TACO? Okay, TACO. Now it can be delayed reaction, delayed. In late, what is more common? It can be again hemolytic. It can be GVSD. It can be post-transfusion purpura, post-transfusion purpura, or can be again disease transmission. Okay, disease transmission. Now, so when we take it delayed and early, if it is say more than 24 hours, after 24 hours we call it delayed, and if it occurs within 24 hours we call it immediate. Within 24 hours we call it immediate. So immediate and the delayed transfusion reaction. Okay, again repeat: hemolytic In non-hemolytic, it can be FNSTR, it can be allergic, can be anaphylaxis, it can be TRALI, TACO, or blood or the bacterial contamination. Delayed can be hemolytic, GVHD, post-transfusion purpura, and can be disease transfusion. Can be disease transmission. Now, among them, let's first understand this FNSTR. See, FNHTR is mainly due to cytokine release. Okay, it's mainly due to cytokine release. So, what you can do is, it may also occur because of antibody against the donor lymphocytes, but mainly due to the cytokine release. So, to decrease FNHTR, it is best if you use leukofiltration. Okay, so leukofilters, I'll just show you one leukofilter. See, this is a leukofilter. So when you take the blood, then there's a leukofilter here. Okay, this leukofilter, as you see here in this image, this is a leukofilter. So as the blood goes here, this leukofilter has some charge-based technique. Suppose it's a negative charge. So this filter will absorb all the positively charged WBCs. Okay, so because of the opposite charge put in the leukofilter, when the blood goes during collection only, you just absorb all the WBCs of the donor, so that this bag doesn't have any of the WBCs, or reducing the WBCs number, and that is called as leukoreduction. So when you don't use this, you get a 1 log reduction because you're centrifuging this, right? And you're building the buffering coat. But when you use this, you get 2 log and a 3 log reduction. That means the glucose had decreased to such a low level, it will not cause FNSTR. Okay, not cause FNSTR. So we usually assume this 3 log reduction with the help of this leukofilter. The question also came in the AIIMS exam last year as to identify what is this. It's a leukofiltration process. Okay, so we can reduce FNSTR by using leukofilters. Now second is TRALI, TRALI. Now friends, what exactly is this TRALI? So what TRALI is, basically it is a transfusion related acute lung injury. It's a transfusion related acute lung injury. Usually the main cause of the TRALI is anti-HLA antibody of the donor plasma with HLA antigen of recipient. This antigen antibody, it goes to the pulmonary circulation and causes findings like ARDS. Usually it occurs within 6 hours, 4 to 6 hours actually of transfusion. Within 4 to 6 hours of transfusion. So why it is happening, see again friends, is main reason is anti-HLA antibody of a donor plasma. And hence comes the question, which component will cause maximum TRALI? Answer is simple, plasma containing. Who is the plasma containing? Fresh frozen plasma, isn't it? Now question is, see, can you guess which donor will have more HLA or more HLA antibodies actually? Those donors who have already got a recipient, that is, he has already got the blood transfusion. That means prior multiply transfused, he himself has got transfusion. So he has got many HLA and his body has made many HLA antibodies. So first thing is multiply transfused person, and second, multiple pregnancies. So these two cases are those conditions which have maximum HLA antibodies, and therefore to prevent TRALI, you should not take blood from these two cases. Okay, let's write that. To reduce TRALI, avoid blood donation, from multiple transfused patient or donor, multiple transfused donor, and multiple pregnancy, multiple pregnancy, multiple transfused donor and multiple pregnancies, and hence you can prevent the trally. Now, next one is TACO, transfusion associated circulatory overload. TACO, it is said to be when you get any four of the following. Number one, acute respiratory distress. Second, tachycardia. Third, increased blood pressure, the hypertension. Pulmonary edema, and positive fluid balance, or raised BNP levels, raised brain natriuretic peptide level. So if you get any four of these, it is TACO. Who will get more TACO? Those patients whose heart is already compromised. Maybe they have a heart failure. Maybe they already have more blood volume like dialysis patients, or the patient who are anemic, severely anemic. So those patients will have more TACO. So TACO increases in compromised heart. Remember, you don't want to put the patient at risk of heart failure in those whom the heart is already very weak. So TACO risk increases in over 60 years of age, or infants, severe anemia patient, and chronic renal failure, especially if on dialysis. So these patients, they are not able to put out more and more water outside the body by urine output, and therefore these patients are increased risk of having a TACO. And you only need to give the management, that is just the symptomatic management for TACO. Symptomatic management which may be done for TACO. Okay, this is for transfusion-related circulatory overload, TACO. And finally, we move to massive blood transfusion. Well, what is massive blood transfusion? Basically, by definition, massive blood transfusion is if you give replacement of more than one time the patient blood volume, within 24 hours. That means if my blood volume is say 5 liters and I get 5 liters of blood within 24 hours, is massive blood transfusion. Or if I get more than 50% of my blood volume within 3 hours. Any of this is basically definition of massive blood transfusion. Findings is very simple again. If you get this amount of blood in such a low amount of time, is it possible for you to get all these blood component in the room temperature? No. You're giving cold blood to the patient. He will have hypothermia. This increased amount of blood may get hemolyzed and causing hyperkalemia. Hemolysis may cause hyperkalemia. This huge amount of citrate going into the patient can cause hypocalcemia. Because of more citrate going to the patient, he may have hypocalcemia. In fact, he may also have the risk of DIC. There may be metabolic alkalosis. Well, because you're giving this patient the CPDA blood, this citrate basically is an alkali. So they can cause metabolic alkalosis. However, if the liver failure is there, what happens is actually the citrate into the blood is converted by the liver to the alkali. Liver converts the citrate into the alkali. If liver is failed, it cannot convert it, and then what can happen is acidosis. So usually it causes alkalosis, but may also cause acidosis. Got the point? So when there is less Temperature of the blood can cause hypothermia. High potassium level because of hemolysis can cause hyperkalemia. It can cause hypocalcemia, may cause DIC because of depletion of coagulation factors, because you're giving a citrated blood. Citrate can deplete all the coagulation factors and can lead to DIC and can lead to metabolic alkalosis. But if liver is failed, it will lead to metabolic acidosis. Metabolic acidosis. Got the point? So, in blood banking transfusion medicine, there is no need to worry. It's very simple if you have the concept. Start revising this whole video from the beginning. Beginning means go to the blood bank, donate blood, prepare the components, do the testing, store the blood components, give to the patient, and store in the blood bank only. Don't store in the vaults. Then look for how do you test for the various antibodies, how do you look for the blood grouping, what if you give the blood and the reaction, there can be transfusion reactions. And this will help you a lot in revising the whole concepts of blood banking and transfusion medicine. Blood banking and transfusion medicine. But yes, donating blood is very important, and make sure every 6 months you try to donate blood. Thank you. I am Dr. Praveen. I hope you liked the video. I will be very waiting for your valuable suggestions and your comments sections. Thank you. Good wishes and best of luck for the upcoming NEET. Thank you.